Hello, friends. Good evening to yet another session where we are continuing the discussions on breast updates from the SABISTON 22nd edition. We saw the last slide, which I think we were checking was on the role of fish and how do you do the immunohistochemistry for 2+ rating. And then you have the two type of fish test where you have a dual tracer ISH can be done where 4 to 16 copies when you have, then you look at the fish to CEP17 ratio. This was the last slide that we discussed. And again, just looking at the gene copies alone, we have less than 4 copies and more than 6 copies is positive, less than 4 is negative. Between 4 to 6, we are supposed to do one more test with a dual tracer and look for the HER2 to CEP ratio, which again, if the ratio is more than 2, then it is considered to be HER2 positive. So this was the one that we were discussing. So now there are a few surgical pointers and other stuff that we need to discuss here. So if you take up some of the recent trials that have come up, so we have the ACASOG 11102 Alliance trial, which is a single arm phase 2 trial. So here they are comparing the role of breast conservation surgery, whether it can be done in multiple ipsilateral breast cancer, what they are calling as MIBC, multiple ipsilateral breast cancers. Traditionally, these were considered to be a contraindication. Currently, even if you have multiple ipsilateral breast cancers, still you can go ahead with breast conservation therapy. That is the current take of the of most of the guidelines that are provided. Now, this was always that we were in practice doing it. Even if you have a patient who has multiple tumors, still we will consider doing a breast conservation surgery. Just having multiple tumors alone is not a contraindication for planning a BCS. Usually, if we can encompass it within a single incision, then definitely yes, we can plan for a breast conservation therapy. Now, this trial, the criteria were there were 2 to 3 MIBCs, like only you should not have multiple tumors. It should not be like, 7 or 8 tumors or 4 or 5 tumors if they are widely spread apart, like when you have a multi-centric tumor. All these are generally considered to be contraindications and they still hold. The criteria that were used in this particular tumor subset of ACASOG Z11102 Alliance trial where most of the subset, if you look at it, they had ER positive tumors, hormone positive tumors. Many of them were again T1. They were early tumors. They should be less than two tumors. I mean, 2 centimeters. Each of the individual tumors should be less than 2 centimeters. And in many cases, almost I believe 80% of the tumor subset here was 2 tumors. It was restricted to 2 tumors, and all of them were T1, N0, pathologically based on SLNB, and preoperative MRI was all done for all the patients in this particular study. And based on that is where they recommended. And after that, they said that yes, you can go ahead with it. So if they ask at a question, it may come as what is the trial for MIBC? Said that's the ACASOG Z11102 trial. So that is the trial which will be done for MIBC or the multiple ipsilateral breast cancer trial. So for this particular, the trial is the ACASOG Z11102 trial. Then you have, we all know about the margin status, which was already mentioned here. I don't know whether it was there in the previous edition. So this edition clearly mentions, we all know about the no tumor at the inked margin for invasive carcinoma, 2 margins for DCIS. Now this we have already mentioned in all the classes. Every time I used to insist that, if the cutoff is not given for an invasive carcinoma, if this particular word is used, no tumor at the inked margin is there, that is the answer that you have to choose. And otherwise, if you do not have that particular option, then you can take it as 1 millimeter. Now, as far as DCIS is concerned, according to the SSO, that is the Society of Surgical Oncology, and the ASTRO guidelines, which is the Radiation Oncology Association. So both of these societies combined together, they have given the guidelines as 2 millimeter margin for DCIS. So for DCIS, because it is a more diffuse process in general, we require larger margins, in the sense that instead of no tumor at the ink margins, we need a 2 millimeter margin. Now, practically what you will do is, again, you will go for a 0.5 to 1 centimeter margin around the tumor. The final margin should be free of tumor. That is what they mean by it. So infiltrative ductal carcinoma, you should have a margin where there is no tumor at the margin for invasive cancer. For DCIS, you should have a 2 millimeter margin. That is what is recommended in the current guidelines, and that has been an update that has been clearly given in your SABISTON 22nd edition. Of course, we have been mentioning this in the classes, but this has now been clearly mentioned in SABISTON, so it is likely to come as one of the MCQs. Now, non-palpable lesion localization, this was again a big class, and whenever we had the breast discussion, we always had a discussion on J-wire lesion, J-wire localization, hook, max seed, all these were discussed. Now, in addition to these, techniques, max seed, iodine 125 seeds, J-wire or the hook localization, all which was discussed for a Birax 4 lesion, whenever you have it, how do you identify and how do you tackle it? There are another couple of things that I mentioned. One is the use of RFID tags and the radar deflectors. Now, these are also tagged on and left in place, and these can be identified by the radar deflectors. And after that, you take out these. Then you have another thing called as find. What does find indicate? It is a fluoroscopic intraoperative node or neoplasm detection. That is something that is new, which is mentioned in the current edition of SABISTON, find. So what is find? Fluoroscopic intraoperative node / neoplasm detection. Now we all know the problem with sentinel lymph node biopsies in these kind of settings is, you put in something to identify the lesion. I mean, not just sentinel lymph nodes, even for these, you put in the clip or you put in the seed or anything like that, but then later on going on and removing it becomes difficult. So that is the reason why we can use, fluoroscopy that can be done intraoperatively. Fluoroscopy should be done intraoperatively to find the clip. That is a new concept which is being done. So that is the fluoroscopic intraoperative node or neoplasm detection. What we commonly do is we try and identify it using other methods like max seed or J-wire, which is something that will be sticking out of the patient. Now we can just put a detector inside. I mean, we can leave the the metal implant inside, and fluoroscopically you can find it real time. You can find it out, and then you can of course resect the tumor and go for a specimen radiograph. All these techniques, ultimately you need a form of specimen radiograph to identify and make sure that that area of microcalcification has been taken out completely. The detection of the individual things varies. For max seed, you use a magnetic probe. For iodine seeds, you use a Geiger counter. For radar deflectors, you use the RFID tag. And for clip localization, either in the nodes or in the neoplasm, that is the fluoroscopic intraoperative node or neoplasm detection, there you use fluoroscopy. So all these are techniques which are new, which are relatively new. Max seed and iodine 125 seeds were mentioned in the previous edition also. This radar deflectors, RFID tags, and the find technique, which is fluoroscopic intraoperative detection, all of these are new. So you can expect some sort of question from this. The principle remains the same. It is just that the name of the techniques have been mentioned here newly, and these fluoroscopy is a new technique, and radar deflectors and RFID tags are again a new technique that have been added to the armamentarium that we have in tackling the non-palpable lesions and also for SLNBs, which can be tagged in the preoperative setting. Right. Now going on to oncoplastic breast surgery. This was again mentioned to a greater or lesser extent even in the previous edition of SABISTON, but they have added a few points and given some few tips and pointers in addition. So one is with regard to the bird beak abnormality. So what do you mean by the bird beak abnormality that we'll have here? So this particular thing, I just took the picture from one of the other sources. So you can see that whenever that there is a lower quadrant tumor which is excised, and there is no ample reconstruction which is done. You have an excision of a lower quadrant lesion and ample reconstruction is not done, then the nipple areolar complex kind of curves down like the beak, like what we see here. Now this picture, when you have, this is known as your bird beak deformity. Now, this is something that can come as a image-based question, or they may ask you as an MCQ, which lesion, where do you get the bird beak abnormality, which area, which quadrant is operated. Any of these questions may come. So in a lower quadrant without oncoplasty, that is where you're likely to get this nipple areolar deformity, which is known as the bird beak deformity. Right. Now, oncoplastic breast surgery, as I already mentioned, when do you definitely need it is when there is a 20%, I mean, more than 20% volume loss that happens in the breast volume. So then you need to plan for an oncoplastic breast surgery. And if it is less than 20%, then you can do something called as level 1 oncoplastic surgery. So this again, we have discussed in the classes. This is the dermoglandular mobilization in the dual plane. Now, in the current edition of SABISTON, we have got a very good description which is given for the dermoglandular mobilization dual plane. So there are two planes where you happen. So one is just underneath. See, once, let's say you have excised a tumor in this area. So one plane is going to be between the skin complex and the breast fat. So that plane mobilization generally we just take sutures like that. The previous era, that is what used to happen. Now you also have to do a mobilization along the plane of the pectoral muscle. So you do in the prepectoral fascia layer, the pectoral fascia you mobilize the dermoglandular element as well. So you're bringing the two together. That is known as your dermoglandular mobilization. So when you do both of them together, so then the cavity is going to get filled properly, and that will lead to a much better cosmetic outcome. So this is known as the dual plane dermoglandular plane and in the prepectoral plane. So both planes you will be mobilizing. Sorry, I have not put the name here. So one plane is the dermoglandular plane mobilization. The second plane is going to be in the level of the pectoral fascia. So both these areas you will mobilize the breast tissue and then you will bring it. That way it will fill in the cavity. Now again, this is one question that is a favorite with examiners. So after breast conservation surgery, if you need to start RT, so when do you do the reconstruction? So if the patient undergoes radiation, after any kind of radiation, when you're planning for reconstruction, that should be done after a period of only 1 to 2 years. So you have to wait for at least a couple of years before you plan for reconstruction after the patient undergoes radiation. Before undergoing radiation, you can do it immediately. That is what is known as the immediate reconstruction. So you do the resection, you do the reconstruction, you make sure the wound heals properly, then send the patient for radiation. So this is what is normally done. In some patients, let's say this patient comes after radiation, after undergoing radiation for this tumor, and then they present to you, they want a correction of this, then you have to wait for at least 1 year before you start of the reconstructive process for them, because otherwise the results are going to be pretty poor. So you have to plan for reconstruction only after 1 to 2 years of radiation as far as your reconstructive process is concerned. So the interval is minimum is 1 year. So that is the MCQ point here. Now, there is a lot which is mentioned about your axillary reverse mapping. So what do you mean by this axillary reverse mapping? Now, this is a technique which is done to avoid the lymphatics that come on to the arm. I already mentioned a couple of slides in the last class about what are the patterns which you have, where you have an apron pattern, where you have a sling pattern, and where you have the other various patterns which are there. You have a sleeve pattern, you have a sling pattern, you have the apron pattern. All these are available. Now, this was done by one of the authors of SABISTON, the breast chapter, which is Klimberg et al. So Bonetti and Klimberg, they published the initial results on identifying the sort of like what do you call this particular um, this axillary reverse mapping. So what they are essentially doing here is they are trying to identify the lymphatics of the arm. So the injection is actually given in the arm. This is to identify the arm lymphatics. And once the blue dye injection is given and that which goes there, then you give a radioisotope injection like usually what we do for the breast. You do not give the blue dye in the breast. So any uptake which is going to be present as only a radiological, I mean the radio uptake which is seen on the Geiger counter, those nodes will all be taken out. Now, if there is an overlap, which tends to happen, there is almost a 20 to 30% or even 40% overlap sometimes with the nodes that drain from the axilla, from the arm. So if there is a drainage which overlaps with the breast lymphatics and the arm lymphatics, then you have to remove it because those are the sentinel nodes. They have to be removed. On the other hand, if you don't have, then you have to just leave it in place. So there is a one trial which is being done for this. This is the Alliance 221702 trial. So I'm not sure how frequently they're going to ask for this particular trial, but these two trials, Lympha trial and the S-Lympha, as I was mentioning even in the previous class, Lympha is basically a lymphatic microsurgical preventive healing approach. That is the LYMPHA. That is the lymphatic microvascular preventive healing approach. That is the Lympha approach. So what you do is whenever you identify any node which is overlapping for the arm lymphatic and for the breast lymphatic, and you are supposed to take it out in case it is an involved node, I mean, in case it is a node which is shown up as a sentinel node also, in that case, you do a microsurgical reconstruction. You identify the lymphatic and you anastomose it to another vein or you anastomose it to another lymph node. So that is known as your lymphatic microsurgical preventive healing approach. Now, there is another thing called as S-Lympha or simplified lympha, where they do the same thing, but here they don't use a microsurgical technique. They just grossly do an anastomosis. So these are two techniques which are done where they observe that there is a reduction in the overall incidence of lymphedema. So when you do the lympha microsurgical technique or the S-Lympha microsurgical technique, they say that the chance of having a lymphedema, because even after doing a sentinel lymph node, there is an incidence of up to 5% of lymphedema in the side on which the SLNB is being done. So to reduce this from 5%, they have shown it is almost equivalent to 0 or 0 to 1% when you follow these lympha or these S-Lympha approach and by using a combination of the your blue dye and other techniques. So when you combine all of this together, you reduce the chances of going in for lymphedema after an SLNB by using the axillary reverse mapping. And that is the outcome of all these trials that are being done. So then there are some new concepts that have come. This trial, this particular sound trial has created a lot of waves in the management of sentinel lymph nodes where you do not do any axillary surgery. So the criteria for this particular sound trial was it is a T1 tumor. When you have an early stage T1, stage 1 breast cancer, T1N0 clinically. So then you go for an axillary ultrasound. Till the stage, it's the same, what we routinely do. Now, if there is any node which you detect on an axillary ultrasound which looks suspicious, there is a loss of the ratio, there is the sort of like, you should have a length is to breadth ratio. The length is to breadth ratio is normally 1:2 at least, meaning it should be an ovoid node. The length is more, so the length should be twice the breadth. That should be the normal. Suppose you have a 1:1 ratio, meaning it is a rounded node. Or if there is some cortical or subcortical deposits which you see, loss of fatty hilum you see, multiple cortical deposits you see, replacement of the node you see, increased vascularity you see. All of these are some things which are high risk features on an axillary ultrasound. Now, when any of this is present, then you have to do an FNAC. So this is applicable only up to a single doubtful node. If multiple nodes are there, then you take it as positive and then you can't proceed with it. But if you find a single node, then you do an FNAC. Now, here comes the randomization bit. So what happens? You have done an axillary ultrasound, you have done a single doubtful node FNAC. Now both of these are negative. Okay, so your evaluation, essentially it shows that clinical evaluation, ultrasound evaluation, and if needed, an FNAC evaluation, all of this are negative. Only then you do an SLNB. So when you have all three negative in a CT1, commonly you will proceed with an SLNB alone. But this was a trial where they did SLNB, and on the other arm, they had no axillary staging. So whenever it was an FNAC negative and an ultrasound negative node, they had two arms. One arm where they did the traditional treatment, or what is currently the traditional treatment, SLNB. If the node is positive, then proceed to axillary dissection. That is one arm. The other arm was you do not do any axillary staging. You leave the patient alone. Basically, you do a wide excision and you leave the patient alone. Don't do any SLNB, don't do any axillary staging. What they found as the outcome of this trial was the DFS was 98% in the observation arm where nothing was done. It was 98%. In the SLNB arm was pretty similar, again 97.7%. So that trial, this particular sound trial, which again was discussed in the San Antonio best surgeons meeting and consensus, this has been the discussion which has been going on for the last nearly 1 year. So the sound trial has basically proven non-inferiority of observation in a patient with a T1N0 where the axillary ultrasound is negative, and if there is something suspicious, the FNAC is also negative. So all these criteria are likely to be asked for you. So in a patient with a sound, in a patient with a sound criteria, meaning it's a clinically T1N0 less than or equal to 2 centimeters, clinically negative axilla, you do an ultrasound of the axilla. Axillary ultrasound should be negative. There itself the rule is satisfied. Or if the axillary ultrasound shows a suspicious node, then an FNAC is done. FNAC is negative. When both of these are negative, then you can observe the patient. That shows a similar survival to doing a sentinel lymph node biopsy. Now, why all this came about is because we are finding more and more tumors which are early tumors, very small, less than 2 centimeters, very favorable subtype, and where the chance of having a nodal metastasis is very low. So they find that this particular subset, it is non-inferior, not doing an axillary dissection in any form, like you don't do SLNB, you don't do axillary dissection, none of which you do, it is still okay. The patient survival is not altered. So the distant disease-free survival was similar to, in the observation arm. So that is the current trial, which is slowly coming up inside the guidelines. So clinically, they may ask you this question: what are the criteria? It is a T1 tumor, N0, axilla should be negative on ultrasound, and if there is a suspicious node on FNAC also, all these criteria are satisfied, then you call it as a patient who's fit for the sound criteria, where you can observe the patient. Right. Now, a few updates on management of DCIS are mentioned here. So one is, the few points that I mentioned are, one is this clustered microcalcification pattern. We all discussed this a lot in BIRAS staging whenever we were having the classes. So most of them, the DCIS will present as a clustered microcalcification without any associated density. So 75% will have a clustered microcalcification, where you will have the pleomorphic microcalcifications all grouped together in one particular area. So this kind of presentation is the most common presentation on mammogram in a DCIS. 10% will have only a density. Okay, so 10% of patients may have only a mass-like lesion which is present there as far as DCIS is concerned, and 15% it will be a combination of microcalcification with density. So this is the presentation. They may ask you the distribution, which is the most common type of finding that you get on mammogram. What is the percentage? That may be a question. Now, whenever you have a patient who has a large size, where the size is going to be, a palpable mass. Essentially, whenever the patient has a palpable mass, size is more than the T1, usually around, 3 to 4 centimeters, at least a large size tumor, high grade DCIS is present, and especially so in the premenopausal age group. So all these people all these ladies are the people who are going to be at a high risk, where you might have a progression to infiltrating ductal carcinoma. So this particular thing, when you have a palpable lump, premenopausal palpable lump, when the size is around 3-4 centimeters large size and a high grade tumor, these are all the patients where you might expect that though the initial trochid biopsy is showing DCIS, the final report may get upstaged to a invasive carcinoma, which happens in around 30% of patients. Most of these will fit into this criteria. The premenopausal ladies, where you have a palpable mass, the size is going to be 3 to 4 centimeters, and it is a high grade tumor. When you have this, then your DCIS is more likely to be showing a progression to infiltrating ductal carcinoma. Right. Now, BCS, we all know the treatment of DCIS in today's world is going to be by doing a breast conservation surgery, and with what is the margin? You have to give at least a 2 millimeter clear margin, and later on followed by radiation. The role of radiation is of course determined by the NSABP B17 and the 24 trials. It's all mentioned in the previous SABISTON and in the other editions as well. So B17 and B24 were the trials for radiation and tamoxifen as far as your DCIS were concerned. So there are a select group of patients where the Van Nuys prognostic index can be applied. So the Van Nuys criteria, where the Silverstein criteria, this was the group, the Silverstein group et al. They actually did the Van Nuys prognostic index, where they studied a list of characters, whether it's high grade, low grade, comedotype, non-comedotype, and then they have the margins which should be more than 1 centimeter, less than 1 centimeter. Based on that, they had a select group of patients where you can treat the patient with only wide local excision alone without any radiation, where we can avoid the radiation. So there are select criteria like this, but the Silverstein trial was proved only in their study. No other study could actually find it. There is also another group called as the Akron group and the ECOG group. So these two groups, again, they did a study, and there they gave a 3 millimeter margin. Like Silverstein et al. Had the 1 centimeter margin, the Akron group had a 3 millimeter margin, where these two groups, they said we can avoid radiation. These two groups, they said we can avoid radiation. These are the select group of patients where we can consider not giving radiation as far as your breast conservation surgery is concerned. You can consider that we can avoid the radiation in these group of patients. Now, there is another trial called as the COMET trial. This is again making the waves now. So this is about not operating on a patient with DCIS, non-operative management of DCIS. So what are the criteria? So it is COMET, the expansion is comparison of operative versus monitoring endocrine therapy in low risk DCIS. So you take the criteria of DCIS. Suppose you have a patient who is clearly postmenopausal, has low grade DCIS, there is no comedonecrosis, it is one of the types like cribriform type. Solid and comedotype are considered to be the high risk. So when you have a cribriform type, it is considered to be a low risk type of DCIS. So when you have a low risk type of DCIS, non-high grade, occurring in postmenopausal, ERPR positive, all of these are the favorable criteria. So when you have the favorable criteria of DCIS seen on a biopsy, on a core needle biopsy, so this trial suggested that you can compare the operative versus the monitoring and endocrine. So you just keep the patient under close monitoring, put them on endocrine therapy with tamoxifen or with anastrozole or with one of the other agents you try. So that is known as your COMET trial, which is now gaining some traction. They are saying that you can avoid operating on these patients with low grade DCIS, which do not actually get converted to malignancy. So you can avoid doing surgery. So that trial is the COMET trial. That may come as a question. So just like we saw the sound where the axillary surgery is avoided, so the same way you can do think of it as the COMET trial, where the COMET trial is for low grade DCIS, where you are avoiding surgery. You are comparing doing surgery versus doing only monitoring and endocrine therapy for these patients, and that is found to be similar as far as the results are concerned. Now, we all know that for management of DCIS, where there are multiple tumors, multiple foci of DCIS, sometimes you need to go for a mastectomy. Now, the current indication is whenever you're doing DCIS, you're undergoing a mastectomy, then you have to do a sentinel lymph node biopsy. Why? Because suppose you have a multicentric DCIS, you're supposed to do a mastectomy, you find that there are multiple areas or diffuse microcalcification is there. You do a mastectomy and then you send the specimen. In that, you find an invasive focus. Now, how will you screen the axilla? There is no way you can do that. You have to do only an axillary dissection because there is no way you can inject and do a sentinel lymph node in the post-operative setting. On the other hand, if you have done a lumpectomy, you can go back and inject into the lumpectomy cavity and also in the perioral region, and you can still do a sentinel lymph node biopsy, whereas this is not possible in patients where a mastectomy has been done for DCS. So traditionally, whenever you do a mastectomy for DCS, you're supposed to do a sentinel lymph node biopsy. Now, there is another trial which has been mentioned, which is known as the SENTI-NOT trial. So as the name indicates, there is no need for doing a sentinel lymph node biopsy in patients with DCS who need a mastectomy. So what they do in this particular trial is, the main principle why we do a sentinel lymph node biopsy is because you have to identify the nodes later on. So how do you identify the nodes? There is no way of doing it. So instead of that, they do an injection of SMIO, or what is known as supermagnetic iron oxide. So these are the something similar to the mag seed. So you inject a supermagnetic iron oxide particle at the site of mastectomy and you leave it in place. So what happens is delayed. Suppose you find out the report shows IDC, then you can go back and you can still detect these by the magnetic probe detectors, and that can identify the sentinel lymph nodes for you. So this trial is known as the SENTI-NOT trial. So it is a way of doing a delayed SLNB basically. So you are doing the injection of the supermagnetic iron oxide and leaving it in place so that later on you can identify the nodes if it is needed in case the reports comes as infiltrating ductal carcinoma. So this is the SENTI-NOT trial. So the trials that you need to remember here are the COMET trial and the SENTI-NOT trial as far as the DCIS is concerned. This is of course in addition to the routine trials that we have like the NSABP B17, which showed the role of addition of radiation improving the cure rates or reducing the number of recurrences, and then the NSABP B24, which showed that adding tamoxifen plus radiation has the best effect on reducing the recurrences as far as DCIS is concerned. Now, what is the role of tamoxifen? Now, previously, for all patients with DCIS, tamoxifen was being given. Currently, it is shown that tamoxifen is only useful only in ER positive DCIS. It is not given routinely for all patients. It is only useful for ER positive DCIS. So you do not go for resection of the, I'm sorry, you do not go for additional adjuvant endocrine therapy in all patients. Currently, even if you have a DCIS, you're supposed to do the ER and PR. HER2, of course, is debatable. There are some people who routinely do HER2 testing, even if it is DCIS. For some, they don't do it because in DCIS with HER2 positive also, there is no role for adjuvant HER2 therapy. So because of this, HER2 is not done routinely in patients with DCIS, but ER and PR are considered that they have to be done. So if it is either ER positive or PR positive or both positive, then you put the patient on tamoxifen for 5 years. Now, other than this, you also have the other two trials that show the role of anastrozole and exemestane. So IBIS-2 and NSABP B35, they were the trials which were done for chemoprevention in DCIS. So they showed the role of anastrozole as far as management of DCIS is concerned. So you can use aromatase inhibitors in the postmenopausal women very clearly. So tamoxifen for ER positive premenopausal, and postmenopausal you will use the anastrozole or exemestane. MAP3, that was the trial which was done. MAP3 was another trial that was done for exemestane, so that can also be done. So MAP3 is the trial for exemestane, and anastrozole is the one which will be used for your DCS. So these are the preventions, chemo preventions that you can do to reduce the rate of recurrences after DCS surgery. So the currently two trials that you have to remember are, one is the SENTI-NOT trial, where you inject supermagnetic iron oxide at the time of doing the mastectomy, massage it so that it goes to the axillary lymph nodes, and later on, in case there is a positive report that is showing an invasive malignancy on your final report, then you can plan for doing a resection of those nodes alone. And COMET trial, where you compare observation versus monitoring and endocrine therapy alone for low grade DCIS. Right. Now comes the role of radiation in breast cancer. So what is the current role of radiation in breast cancer? Now we all know that what are the indications for post mastectomy RT. So any patient who has got a tumor which is T3, basically more than 5 centimeters, we have to plan for post-mastectomy radiation. Now, remember, friends, whenever we say post-mastectomy radiation, we are talking about radiation which will be given to the supraclavicula, to the internal mammary area. So these are the two areas, and also, of course, to the bed, to the basically the chest wall. So chest wall radiation, internal mammary radiation, and the supraclavicular radiation. This is what we normally say. And there is another term that you have to know, what is known as RNI, or regional nodal radiation. So when you talk about post-mastectomy regional nodal radiation, you are referring to the supraclavicular to the infraclavicular level 3. I mean level 3, both the nodes, supra and infraclavicular, and then the internal mammary. These are considered to be the regional nodes. The axillary nodes you have already addressed, either in forms of a sentinel lymph node or in the form of an axillary dissection. You have already done that. So axillary lymph nodes are not traditionally included as far as the renal node irradiation is concerned. Now, when will you give axillary radiation? So there are some few indications where you have an extra nodal extension and bulky nodes are present. Even after doing an axillary dissection, you can give radiation to the axilla. So this is one point that you have to remember. Common treatment, axilla is done by a single modality treatment. You either do surgery or you do radiation, one of the two. So surgery, how do? You do a sentinel lymph node biopsy. If the nodes are negative, you can leave them alone. Second, you can do an axillary lymph node dissection. Either of these two you do, and that's it. No other treatment is needed. Now, there are select few cases where there are multiple bulky nodes in the axilla, where there is gross extranodal extension which is present. In such cases, you can give additional radiation to the axilla. That is a selective recommendation as far as the NCCN is concerned. Now, when you take up regional nodal radiation, as I said, it's only the supra-infraclavicular nodes, basically the level 3 and also the internal mammary chain. Only these are considered as the regional nodal radiation. When you talk about RNI, regional nodal radiation, these are the things which are concerned. So when you talk about post-mastectomy RT, what do? You radiate the chest wall, you radiate the supraclavicular, infraclavicular, and the internal mammary. These are what is routinely done as a post-mastectomy radiation. So what are the indications? Any tumor which is more than 5 centimeters in size, where you have a margin positive status on a mastectomy, then you have to consider. So then again, others are soft indications, like when you have, your perineural invasion, when you have an extranodal extension in the primary, then you radiate the external nodes. So extranodal extension, when you have perineural invasion, when you have LVSI, high grade tumors, these are all the low risk factors. And I mean, these are all the relatively, kind of like low risk factors. Definitely, when you have to give any mastectomy patient where the tumor is more than 5 centimeter is one. And again, whenever it's a margin positive status where the deep margin or some margin is turning out, usually it's the deep margin that will be positive. So if you have the margins which turns out to be positive, then you have to plan for radiation. So this is how you'll have to plan for it. So this is the indication for post-mastectomy. And of course, we all know that any patient who undergoes a breast conservation surgery, it is always a breast conservation therapy. So you do breast conservation, you have to do add and radiation. So that is known as breast conservation therapy. Now, there are two trials that have established that you can avoid radiation after doing a breast conservation surgery in a select group of patients who are more than 70 years of age. So elderly women more than 70 years of age, after doing breast conservation surgery, you can avoid radiation. This was given by the CalGB 9343 and the Prime 2 trials. So these two trials can be asked. So Prime 2 and the CalGB 9343 trials. So these two show that you can avoid breast conservation therapy, meaning you can only do a BCS, avoid avoid radiation after BCS in these particular patients aged more than 70 years when based on the Prime 2 and the CalGB 9343 trials. Right. Now, how do you develop or how do you give the radiation? Now, the radiation is generally given, historically, it was given as 25 fractions of radiations, each 2 gray. So totally it will be given over a period of 50 gray, meaning 5 weeks. 5 weeks is 35 days totally. You will have 5 days a week, 2 days gap, then 5 days a week, 2 days gap, like that you will give for 5 weeks. So total of 25 days actually you are giving, but over a period, if you look at it, is 35 days totally. So 25 fractions, 35 days and 50 gray of radiation. This was the historical standard post-mastectomy radiation. Now there was a fast trial which was done in Canadian trial, the Canadian fast trial as it is called as. So they gave a hypofractionation. Many of the patients, the problem is not giving the surgery. Breast conservation, the problem is not surgery. Surgery is usually done. Two things which will be a problem. One is the availability of frozen section resources at the facility, sentinel lymph node and frozen section. The second one is going to be the use of radiation. Radiation facility may not be available. Patients may have to travel long distance for radiation. So to cut down on the number of fractions which are needed, to reduce the time needed for treatment, currently what is followed is a 3-week hypofractionation. So how is it done? It is done as 42.5 gray in 16 fractions given over a period of 22 days. So 16 fraction radiation, or some people have even made it as a 15 fraction radiation now. So they give this 42.5 gray over a period of 3 weeks, 5 days a week for 3 weeks. That is what they are giving. So when they give this 42.5 gray over 3 weeks, then that is considered to be equivalent, and currently that is the standard of care. So currently if you ask what is the standard of care in post mastectomy radiation, so that is going to be 42.5 gray in 16 fractions given over 22 days. This is the current standard of care in managing patients in post mastectomy radiation. Then you have the fast forward trial, which you are compressing this entire radiation within 1 week. So you are giving it as 5 fractions, 26 gray. So that trial is kind of like, kind of in a very, very favorable subset. You can consider all this, like what we consider as the APBA subset. You remember in our classes, we were discussing about, suitable group for APBA, extended group for accelerated partial breast radiation, and a unsuitable group. So when you have a group who is kind of suitable for that APBA, similarly, we can use the fast forward trial protocol, where you can give, after undergoing a breast conservation, you can plan for 5 fractions of radiations, 26 gray within a week. Basically in 5 days you complete the radiation. That of course the patients will be more sort of like welcoming it better, because they can finish the radiation in 1 week and they can go back and they start their other therapies. So that is what they will prefer as far as the management of the patients is going to be concerned. So the types of radiation is not really changed. It's only the duration of radiation. So post mastectomy radiation, which was 50 gray in 25 fractions, current standard of care is 42.5 gray in 16 fractions over 22 days. So this is a question that can come, because even in esophagus they are fond of asking these questions in according to the trial that we have, the cross protocol. What is the number of gray of radiation which is given over what period of time? All this is something which is asked. So same way they can ask you in breast cancer, in your mastectomy, what is the post mastectomy radiation dose? That is 42.5 gray in 16 fractions over 22 days. That is the current standard of care. The newer one, which is based on the fast forward protocol, is of course based on 26 gray in 5 fractions. You give an even shorter duration of radiation. You give it only for 5 days, 5 fractions. 26 gray is given. That is being evaluated. That is not at the standard of care for these patients. Right. Now, post NACT, there are another couple of trials where they are reconsidering the role of radiation and also reconsidering the role of surgery. Now, the two trials which are important in this criteria are, one is the NSABP B51 trial, which is also known as the NRG Oncology or the RTOG 1304. Just remember as B51. So for this B51 trial, what are they actually checking? So in a patient where you're doing neoadjuvant chemotherapy, where there is a complete nodal response. So how do you assess this complete nodal response? One is by your metabolic response, which is based on your PET scans, and the second one is based on your SLNB technique. We all know that there are NACT, post NACT, there are 3 trials already mentioned in the previous edition of Bailey and in SABISTON. So that was the SN-FNAC trial, the Sentina trial. So these 2 trials which showed, then the Akazog Z1071 trial, 3 trials, Akazog 1071, the Sentina trial, and the SN-FNAC trial. These were the trials that showed that there is a role of sentinel lymph node biopsy in a patient post NACT. So some updates based on the trial were like those trials have to be done. Based on those trials, when you're doing a sentinel lymph node biopsy, you have to plan for at least a dual dye technique. 2 dyes have to be used absolutely, because single dye or dual dye is acceptable in the primary setting, but in a post NACT setting, definitely 2 dyes have to be used. At least 3 nodes have to be detected. In SLNB, minimum number of nodes is actually not mentioned in a primary SLNB. That is, without giving any therapy, if you're doing SLNB, even 1 node is taken, that is sufficient. But in a post NACT SLNB, at least 3 nodes. So 2 dyes, 3 nodes. 2 dyes have to be given and 3 nodes have to be taken. So that is the standard of care. And of course, you have to combine it with something called as the targeted axillary dissection. What do you mean by targeted axillary dissection? Meaning, upfront, you have a node which appears to be positive. You put either the clip or the India ink or the Max seed or the RFID tracer, or you can use any of the techniques which are available So any of this you do inside, you put it, you target it before you start the therapy. And at the end of therapy, this particular node has to be removed. So this is known as your targeted axillary dissection, as we have discussed after the previous update of SABISTON came. So that is known as TAD. So you follow three techniques. One is 2 days have to be used. Second one is at least 3 lymph nodes have to be detected. Third is TAD has to be done. Now, when you do all this, you have done an SLNV and then you find that there is a complete nodal response post NACT. So is there a role of regional nodal radiation? That is being questioned by, because traditionally, whenever you have any patient who has an N plus disease, then obviously you have to plan for radiation. That is one more indication for post-mastectomy radiation. So you have node positive, margin positive, post BCS scenario, and I mean node positive, margin positive applies to all the scenarios. And then whenever you have a breast conservation, obviously you have to give, and in the post mastectomy again more than 5 centimeters when you have, that has to be given. So now in this particular thing, even though the patients are initially node positive, when they have a good response to chemotherapy, to the neoadjuvant systemic therapy that has been given, so then in these patients the radiation can be avoided. That is the NSABP B51 trial. Similarly, you have the Alliance A, 11202, the 11202 Alliance A trial. So that is the one where post NACT, they are comparing two arms. One arm is you do axillary lymph node dissection with regional nodal radiation. Okay, so what do you mean by regional nodal radiation? As I already mentioned, it's the level 3 supraclavicular, infraclavicular, internal memory. This is one arm. The second arm is you treat the patient when they have, this one with axillary radiation with RNA. So basically you're complaining with, essentially you're comparing a either doing an axillary lymph node dissection or axillary radiation with regional nodal radiation. That is the ACASOC Alliance A 11202 trial. A 11202 trial is based on this. So here you do not do an axillary lymph node dissection on one arm, the other arm you do an axillary lymph node dissection. This is based on the SLNB reports after NACT. So both these trials follow the same thing. You have a patient who has initially node positive disease, you give the patient NACT. In the NSABP B51, they address the role of giving radiation to the supraclavicular, infraclavicular, and to the regional internal memory nodes. This is one trial. The second trial is the ACASOC A 11202 trial. In the A 11202 trial, you are actually comparing whether you have to do an axillary dissection at all. So whether you have to do an axillary dissection at all, that is being compared in this particular trial. Sorry, I lost the screen share. Yeah, so they're comparing whether you have to complete the axillary dissection. Yeah, sorry friends, just tapped out. So this one was, there are two trials. Both the trials you are comparing post NACT. Post NACT, you're taking the nodes if the nodes are negative, meaning they have completely responded to your initial systemic therapy. NSABP B51 compares the role of whether radiation to the internal memories, supraclavicular, and the infraclavicular nodes has to be given. This is the B51 trial, and the ACASOC 11202 trial is the one where it compares axillary nodal dissection on the other hand with axillary radiation. So these are two different ways of approaching a patient with any kind of residual disease after undergoing an NACT. So these are the trials that are there. Now all the other things which are given here in the book are pretty much standard. So they have again reiterate the role of your oncotype DX. What is the recurrence score that you have to take, 11 and 16. So in any patient where the score is premenopausal and more than 16 or more, then you have to plan for chemotherapy as far as the Oncotype DX recurrence score is concerned. Then they have given the other trial, which is mentioned as the RX Ponder trial. All this was there even in the previous edition of SABISTON. Then they have compared the role of adjuvant therapy with Herceptin. So when you go for neoadjuvant treatment with Herceptin based on a Trifina affinity trials and all that, which was there in the previous edition. So you got a patient who's got a HER2 positive disease. You currently treat the patient with some regimen called as TCHP, taxane, docetaxel usually, then carboplatin, Herceptin. TCH was the regimen that we discussed. So TCH along with pertuzumab you add on. That is based on the affinity and the neosphere trials. So that you give, and at the end of therapy, after giving all the 6 cycles of chemotherapy, you do the surgery and then you take out the specimen and then you see if there is a complete response in the primary and in the nodes, which is known as your pathological complete response or your PCR, then you can leave the patient alone. On the other hand, if the patient has got any kind of residue in the primary and in the nodes, then you have to treat the patient by adding TDM1. You have to add on TDM1. Now, this was all there in the previous edition. I just thought I'll mention because they have given it a little bit more in detail, but essentially they have not changed the criteria here. Again, the management of patients by giving neoadjuvant chemotherapy, what is the response assessment, the NSABP B27 trial, all of these are mentioned in the current edition of SABISTON, which were similar to the previous edition of SABISTON. In the systemic part, actually, I didn't find a lot of changes that have happened. Most of these have been trials based on breast conservation surgery. The sound and the comet trials were important. Then you have the NSABP B51 and the ACASOG trials, which have been stressed based on no surgery or no axillary surgery. So overall, there is a trend towards doing less of axillary surgery, avoiding a nodal clearance. So that is one thing. Then they have clearly mentioned the fast and the fast forward trials with regard to radiation, meaning giving the 42.6 gray, 42.5 gray radiation over 16 fractions. That is one. And again, 26 gray in 5 fractions radiation. So these two are discussed in great detail. And again, avoidance of radiation based on the 9343 CalGB trial and the Prime 2 trial in patients with age greater than 70 years. In if they are having a BCS also, you can avoid radiation. So these are the latest trials that have come up where there is a de-escalation strategy. Basically, there is a lot of de-escalation which is happening that has been stressed a lot, and I think we will get questions based on that in our current NEET or INSS examinations. So that, my friends, concludes the updates and breast. I'll be coming up with the updates in the other topics of SABISTON as well, like it may be head and neck, it may be your melanomas and skin sarcomas chapters. So that also I'll be dealing with over the coming week. So all the best, my friends, and let's meet over the next class. This, I think, will complete the session for today. I will be sharing the PDF of the PowerPoint tomorrow. I was just waiting to complete the session so that I can share it in its entirety and make use of it, my friends. Thank you.